Hello, it's nice to meet you. My name is Go Akiyama, and I am a member of the Plastic Surgery Department at Nippon Medical School Hospital. I am very grateful for this valuable opportunity. Today, I would like to talk about wound management, debridement, and the use of artificial dermis. First, let me briefly introduce our institution. Our hospital is located in Tokyo and has 877 inpatient beds, and our facility has one of the leading critical care centers in Japan with 60 ICU beds, and emergency physicians are available for patients with extensive burns, patients with multiple trauma including facial and extremity injuries, and patients with severe soft tissue infections. There are 14 emergency specialists and 13 plastic surgery specialists, and we work with many resident doctors on a daily basis, and we are cooperating in the treatment. In 2023, the number of plastic surgery operations was about 1,500, and the number of outpatients was about 24,000. Let me talk about wound management at first, and then next I will talk about the use of artificial dermis. Here I will briefly discuss these 5 points. Number 1. Introduction. Wounds occur as a result of accidental or surgical trauma and from a variety of medical conditions, and acute wounds go through stages of healing, and signs of healing are well defined within 4 weeks, while chronic wounds do not undergo normal progression through the healing phases, and healing is not apparent within 4 weeks. The wound healing process depends on many factors. Number 2. Wound healing is a complex process of replacing damaged and dysfunctional cellular structures and tissue layers. This diagram shows the 4 stages of wound healing process. Here are the 4 stages of wound healing. First, hemostasis. The bleeding clot fills the defect and stops the bleeding. Second, inflammation. Inflammatory cells like neutrophils, monocytes, macrophages, etc., migrate through the wound. They are often symptoms of edema, erythema, and pain. Third, proliferation. Fibroblasts migrate from the periphery, remodel the extracellular matrix, initiate angiogenesis, and form granulation tissue. The wound is healed with flesh collagen and extracellular matrix tissue. Fourth, remodeling. Epidermal cells migrate and the wound shrinks and closes. The third proliferation phase is thought to be the most important phase in these processes. In chronic wounds, the inflammatory phase is often prolonged. In order for chronic wounds to transition from the inflammatory to proliferative phase and then to the healing phase, wound bed proliferation (WBP) is necessary. Number 3. This table shows the factors that inhibit wound healing, including local and systemic factors. Local factors consist of bacterial colonization, fibry coating and necrosis, wound infection, poor wound hygiene, poor blood supply, hypoxemia, debris, and pressure, while systemic factors consist of cardiovascular disease, neuropathy or diabetes, metabolic disease, malnutrition, medications, for example steroids, immunosuppressants, aging, and smoking. And this diagram depicts a balance between healing and chronic wounds. In healing wounds, you can see high mitogenic activity, low inflammatory cytokines, low proteases, and mitotically competent cells, and the opposite occurs in chronic wounds. If we can raise the stage of wound healing from a chronic state to a state of healing, we can transition the stage to wound healing. Number 4. Wound bed preparation and time concept. Wound bed preparation, WBP, refers to removing factors that inhibit wound healing and creating an environment for wound healing, and in particular refers to removing wound healing inhibitors that are inherent in chronic wounds. Local management of a non-healing wound involves an ongoing debridement phase, management of exudate, and resolution of bacterial imbalance. In 2003, the components of the evolved WBP were organized and the time concept was announced, combining the initial letters of the components: tissue, infection or inflammation, moisture, and edge of wound. The WBP algorithm begins with a patient assessment based on the systemic and local factors identified through the patient assessment. Each of the time items is managed. And this is a table of each element of the time concept. I will not go into details here. This is also a table of each element of the time concept. Number 5. Debridement. Here I like to talk about the 3 points about debridement. Regarding debridement, we use a new device called a hydroionic debridement machine. In addition to surgical debridement, we also perform debridement using enzymes. Necrotic tissue is removed macroscopically using an electric scalpel, sharp cullets, or dermatome to flatten the wound. As shown in this slide, there are several methods for debridement of burns specifically. This is tangential excision performed by dermatome, excised up to the border between viable and necrotic areas. This is a before and after photo of debridement over an extensive burn patient. We usually perform both facial and sequential excision. The decision as to whether to preserve the subcutaneous tissue or to remove the subcutaneous tissue above the fascia is based on the patient's condition. Now I'd like to talk about a hydrosurgery device called Versajet. It is a medical device that uses high-pressure water to remove necrotic tissue. The technology uses high-velocity water flow, allowing precise selection of the area of resection while sparing healthy tissue and enabling simultaneous removal and evacuation of necrotic or infected tissue, bacteria, and contaminants. This is a before and after photo of the hydrostatic debridement. In this case, SDB, superficial dermal burn, and DDB, deep dermal burn, were mixed, and by performing hydroionic debridement, the necrotic tissue on the dorsal side of the thigh was neatly flattened. In this case, epithelialization was achieved without any skin grafting. This is the same case using the Versajet. High-pressure water water comes out of the tip of the device and is simultaneously aspirated, allowing for the removal of necrotic tissue while flushing the wound. In this case, we use the burst-jet to debride the forearm. Since it can perform precise debridement, I think it is suitable for burns on the forearm, hand, and face. Next, regarding chemical debridement using enzymes, topical medications containing bromelain, a proteolytic enzyme found in pineapple, have been available. In addition, recently, products that can selectively remove necrotic tissue have become available. This product, called Naxivulate, or KMW1, is said to have the advantage of being able to selectively remove only necrotic tissue compared to surgical debridement. When using Naxivulate, the compounded topical medication must be applied to the affected burn area for approximately 4 hours or more. This is a recent case in which Naxivulate was used in our facility. Although some of the yellow necrotic tissue was removed, it was not completely removed. In this case, it was a low-temperature burn, and about 2 weeks had passed since the onset of the disease, so it is thought to be less effective. In addition, a spray of basic fibroblast growth factor, basic FGF, can be used from 20 years ago in our country. The basic FGF is a multipotential glycoprotein that promotes many cells such as dermal fibroblasts, keratinocytes, endothelial cells, and melanocytes. And when used for burn ulcers, it promotes wound healing by forming good coordination with abundant new blood vessels. At our institution, we use this for every wound treatment and surgery. It can also be used for pressure ulcers as shown in the picture. After debridement, the wound is covered using dressings such as autologous skin grafts, allogenic skin grafts, artificial dermis, or silver perforations. Allograft is used when resources are available, and recently artificial dermis is used while being careful of infection. So I'd like to talk about artificial dermis. First, I'm going to talk about the characteristics and uses of artificial dermis, and the next topic is its indications and actual usage. Artificial dermis is developed for the purpose of constructing a dermis-like structure and has a two-layer structure of collagen sponge and silicone sheet. After application, a dermis-like structure is built within the collagen sponge in about 2 weeks. The key points for using the artificial dermis is: 1. By using the artificial dermis, a good transplant bed can be constructed for skin graft. 2. It takes about 2 weeks to construct the wound bed. 3. It's vulnerable to infection compared to allograft. Thorough debridement is important. You may be wondering that can artificial dermis be an alternative to allogenic skin grafts? Ludwig reported that there was no difference in skin graft survival rate, complications, mortality rate, or length of hospital stay between the two. I will show you some actual cases where artificial dermis has been used. This is a case of Bowen's disease on the right lower leg. After extended excision, artificial dermis was applied. After checking the pathology results, split-thickness skin grafting was performed 3 weeks after the initial surgery. Artificial dermis can be used as a wound dressing until pathology results are available. This is a case of abdominal DFSB, which stands for dermatofibrosarcoma protuberans, After extensive dissection, artificial dermis was applied similarly, and after the results of the pathological examination were available, the wound was closed with a local flap. As can be seen in the photo below, the wound tends to shrink after application of the artificial dermis, so if the skin defect is small, it is often possible to achieve wound closure by simply applying the artificial dermis. This is a scald burn on the left foot, and after debridement, artificial dermis was applied. Artificial dermis may be applied to the isolated area where tendons or bones are exposed. This is a diabetic ulcer on the left foot. After debridement, artificial dermis was applied to improve the wound environment, and then split thickness skin grafting was performed 3 weeks after Pelnac application. As we have seen so far, artificial dermis is used for chronic wounds such as intractable ulcers, acute wounds such as burns and trauma, and open wounds after tumor removal. This is a procedure for attaching the artificial dermis to the previous case. After soaking in saline, the artificial dermis is attached to the ulcer surface. And this is a case of 65% flame burn. This is a photo taken on the 7th day after the injury and debridement has been completed. An allogenic skin graft was performed on the anterior chest during the previous surgery, and this time on the left upper limb. This is a photo from the 11th day. After maintenance debridement, artificial dermis is applied, as you can see in the green circle. At our facility, we perform allogenic skin grafts when available. However, as resources are limited, we also actively use artificial dermis. After that, split thickness skin grafts were performed repeatedly, and the patient was transferred to another hospital for rehabilitation on the 118th day, as his progress was good. This was the same patient about 600 days after the injury. The progress of the wounds after skin graft is cosmetically satisfactory. We are considering scar contracture revision surgery on the neck and armpits in the future. And this is the end of my presentation. Thank you for your attention. I will be honored if I could be of any help to you. If you have any questions or something to ask, please contact me anytime at this email address. We are looking forward to working with you in the future. Thanks a lot.